Hi everybody, welcome back to the Blood Bank Guy video podcast. This is Joe Chaffin. It's October 2012, and today we're going to be talking about the D variants. I call this lecture Week in the Ds, which kind of makes me laugh because I think it's a little clever. You may not, but I kind of do. If you don't know what the D variants are, then you may be listening to the wrong podcast. It's basically a look at the different variants, in particular weak and partial D, that we see in association with the Rh blood group system. Before we get to that, though, I just want to remind you that this podcast is not a medical consultation. The opinions that I'm expressing are mine and not those of any organization with which I'm affiliated. And finally, I would appreciate it if you wouldn't either reproduce, modify, or rebroadcast this podcast without my permission. That being said, I only say that to people because I don't want anybody charging for this. It's intended to be free, intended to be for public use. And if you just shoot me an email through the website, I generally will give permission. But again, just please do that before you rebroadcast this podcast. My goal, as always, is to kind of shine a light on the basics of a particular topic in blood banking, and hopefully illuminate it a little bit more for you. I've chosen to look at the D variants, in particular weak and partial D, just because I get so many questions about weak and partial D. People tend to be a little bit confused about how they work together, how their historical ideas may be different from what we're seeing in modern blood banking. So I want to take you on a quick trip through it. I'm going to talk about the basics of RhD first, some trends in testing, and then spend most of our time talking about the historical and modern views, in particular of weak D and partial D, a little bit on testing at the beginning and end, and some recommendations. Well, where do you see these in real life? Here's just a couple of examples that I just want to run by you. A longtime blood donor who swears that she's Rh positive. She's been Rh positive for years as a blood donor. All of a sudden, she comes in for a transfusion and she's testing as D negative. How can that happen? Second, a prenatal patient who was Rh negative when she's admitted to the hospital, but all through her pregnancy has been managed as being Rh positive. Again, D variants are one possible explanation for how that particular interaction could occur. Then an Rh negative patient who's received no Rh positive blood but now has an anti-D. Oops. Or the opposite. A patient has a new anti-D but is Rh positive in your transfusion service. And finally, platform changes can lead you to discussions of D variants as well. When you've recently switched, for example, to the orthogel system after testing for years with tubes, and now someone who was D negative before comes out as D positive. Again, as we go through this discussion, I hope that all of these will kind of be illuminated for you, and you can see how these kinds of things could, and in fact do, happen. But before we get to that, we need to take a quick tour through the genetics of the Rh system. I hope some of this is review for you. This is not a genetics lecture, so I'm not going to go into enormous detail. But remember, for the main Rh antigens, all the action happens on chromosome 1. You've got the RhD gene that codes for the presence or absence of the D antigen, and you've got the RhCE gene, which gives you various combinations of big C and little c and big E and little e. There are obviously other Rh antigens, and then there's the RhAg gene, which is on a different chromosome, but we're going to focus primarily on the D gene today, a little bit on CE as well. Well, what can happen with RhD? Well, if as in this particular slide, you see someone who has two copies of a normal RhD gene, as shown in red there, then obviously they're going to be D positive. Now, some people have deletions of that D gene, so they only have one copy. They only inherit one copy from one parent and a deleted copy from the other parent. Well, in that case, they're still going to be D positive, and in fact, serologically, it's going to be next to impossible to tell that person from choice 1, where a person has two copies of the gene. The D antigens and antibodies don't particularly show much in the way of dosage. Dosage is a phenomenon we've talked about before in a different podcast. Then, on the other hand, you can have some variants. Oh, well, first, you could have 0 copies, obviously. You could get deleted forms from both parents, and in that case, clearly you would be D negative. And then you could have the abnormal copies that I was mentioning before. You could have a variant D gene. Now, we show the D gene in red as a normal D gene here, but you should realize that there are multiple, well over 70 different Rh variants that have different alleles of the D gene. And I show one of these here in purple. It's not any particular one, but if you have one abnormal and one normal, in most cases you're going to be D positive. You may have some variation in how your D antigen is expressed. On the other hand, if you inherit only one copy of a variant D gene and your other chromosome has a deleted form of the RhD gene, well, then you're going to have a D variant. Or you could also actually, in that scenario, be a D negative. In other words, if that abnormal RhD gene codes for example, a premature stop codon, as we commonly see in African Americans, that doesn't give you a viable form of the D antigen, well, then you would actually look like you were D negative. Or you could be a D variant like weak or partial D, as we'll talk about. You could also receive 2 copies of the same D variant gene, or 1 copy of one D variant gene and 1 copy of another D variant gene. And again, that gets complicated and weird, and we're not going to take the time to talk about it today. RhCE, on the other hand, I just want to show you real quickly, it codes for different different combinations of big C and little c, such as the combination big C, little e, little c, big E, little c, little e, big C, big E, for example. And again, we're not going to take the time to go over those today. I do want to mention the haplotypes for you, the combinations of the shorthand combinations of big D, big and little c, big and little e, that you're just expected to know in blood banking. We've gone over these before in a previous lecture, so I'll be really quick. Remember, everything in the first column on the left that has the big R's is going to be D positive. Everything in the second column on the right that has the little r's is going to be D negative. So that tells you how that goes. Now if we look in rows, in the first row we have a 1 and that for big R, and then a single prime or little r prime for the Rh negative version. Well, in both cases, either the 1 or the single prime tells you that the big C is the one capitalized between C and E. You can see how this goes. If you have 2 or double prime, the second one is capitalized, or the E. If you have a 0 or nothing, as in little r, then neither one is capitalized. And then finally, if you have any letter, such as Z or Y, then both of them are going to be capitalized. Again, I went through that quickly. I hope that's a review for you. If it's not, you can look at a previous podcast or listen to a previous podcast where I take a little longer to go through that same explanation. But you've got to know this terminology. Genetically speaking, again, on chromosome 1, you've got the two forms, the two genes, RhD and RhCE. They actually are very close to each other. They're actually adjacent to each other with a little area called SMP1 in between them. And if you notice the numbers on here, 1 through 10, basically those are exons, or areas of the gene that are coded, or transcribed, I should say, to create viable protein. And in fact, if you'll notice, you have for RhD, you have 1 through 10 if you go from left to right. For RhCE, you have 10 through 1 if you go from left to right. It's thought that allows these genes to actually kind of have a little bit of a hairpin configuration, where exon 10 is across from exon 10, and 1 is across from 1, etc. As you can expect, as you would imagine, I should say, this allows for the possibility of some interactions between these genes. But most commonly, you don't get the kind of interactions that you might expect. In other words, in something like this, genetically speaking, we would commonly expect to see something called crossing over, where a portion of RhD goes to RhCE and the corresponding portion of RhCE goes back to RhD. But actually, typically with these, you get, more commonly, you get something called gene conversion. And gene conversion looks like this, where if you look at the RhD in this form, exons 4, 5, and 6 have been replaced with the exon 4, 5, and 6 from RhCE, but you don't have the corresponding exchange on the RhCE gene. That's gene conversion. In other words, one gene changes, the other gene stays the same as it was before. The one that you see there is actually specifically the mutation that you see in partial D6, which is the most common form of partial D in Caucasians. If you're D negative, on the other hand, there are several different options. Remember, there's no such thing as a little d gene. Caucasians are D negative about 15% of the time. In most cases, they just have a deleted RhD gene completely, or 2 copies of a deleted RhD gene, I should say. 2 chromosomes that lack RhD gene. There you go. African Americans, considerably less commonly D negative than Caucasians. They can have that same deletion kind of deal, but they also commonly have what's called a psi pseudogene. That pseudogene has a premature stop codon. I mentioned this before, so you don't get a viable transcribes D antigens, so they look D negative. Asians, on the other hand, very, very uncommonly D negative. They can have point mutations in the D gene, and in fact, many Asians that appear D negative aren't really D negative at all. They're actually a D variant that we'll talk about later, known as DEL. More on that in a bit. Graphically speaking, here's how the Rh antigens look, or one version of how they look. And please notice the credit at the bottom of the slide. This is from an excellent, excellent summary of the Rh blood group antigen published by Connie Westhoff in 2005 in Immunohematology. Awesome talk, awesome article, and I would highly recommend it to you. This particular illustration shows that there are some differences, obviously, between RhD on the top and RhCE on the bottom, but there are a lot more similarities. There's somewhere in the range of 32 to 35 amino acids different. Sorry, I skipped through that a little quickly. This is another illustration from a different article in 2006 by Bill Flegel. Specifically, this shows, I want to call your attention to the fact that if you notice, the majority of the D antigen is actually present within the membrane or within the inside of the red cell. And out on the surface, there's not all that many amino acids. And those amino acids that are out there, surprisingly, despite the fact that there are so few of them, actually make up over 30 epitopes. Epitopes are simply antibody binding sites, places for antibodies to bind, and you can see there's a small number of amino acids out there, but they're formed in a very complex way that gives you over 30 places for antibodies to bind. And speaking of antibodies binding, how does that work? Well, traditionally, when we're testing someone for the presence or absence of D antigen, we used forms of anti-D that were polyclonal. They were IgG. They came from people that were naturally immunized to the D antigen. And actually, in the forms in which we use them, such as making them very high protein, such as modifying the IgG to make it more flexible, they were actually really good at agglutinating D positive red cells. And here's how it worked. You throw in some D positive red cells, you throw in your anti-D, that IgG anti-D would bind and directly agglutinate, and you would get a very strong reaction. Now, on occasion, in fact, pretty uncommonly, but on occasion you'd see a situation where someone truly was D positive, and that anti-D would actually not agglutinate the red cells, but it would just bind and coat the red cells, but not agglutinate them. So you'd get a negative reaction in the tube, as you see up there at the top. Well, the solution to that was to do what became known as the weak D test. The weak D test, simply you would wash away any unbound anti-D, then throw in anti-human globulin, which would bind to the anti-D which was coating the red cell but not agglutinating it, and that would give you a strong reaction. And those of you that have been around blood banking at all will know that what I'm describing there is simply an indirect antiglobulin test. So a weak D test is simply an indirect antiglobulin test which is performed on someone who has had a negative direct agglutination test with anti-D, just to show that they really are D positive. Modern anti-D, on the other hand, uses a combination, typically. A combination of a monoclonal IgM, which is excellent at agglutinating and directly agglutinating D-positive red cells. Remember, IgM is much better at direct agglutination than IgG is, so you would expect this to agglutinate a D-positive red cell very well. But in addition, most of these are present in combination with either a monoclonal IgG or a polyclonal IgG. Really, that IgG in this setting is kind of for backup. It's to allow you to do a weak D test if the person doesn't test positively with the monoclonal IgM. So it's all one mixture. It's not like you add them separately, but it's one mixture. And let me show you how that works. Again, monoclonal IgM added to IgG, but at the same time, it's in a mixture. You get the IgG monoclonal or polyclonal anti-D that comes in, but you usually don't need it because this is what typically happens. That IgM is great at binding, agglutinating, giving you a strong positive, and you get someone who appears D positive. But occasionally, much less commonly than with the old forms of anti-D, you would get this, where the same sort of thing. You just get binding with the IgG anti-D, no agglutination, and you have to do an IAT or a weak D test again to prove that that person really is D positive. First, wash away anything unbound, throw in the AHG. That will bind to the coated red cells and prove that the person really is D positive. So a lot of reasons for the complexity of this testing, including the reagents that we use, the phase that it's read, the platforms, more on that in just a second, and the complexity of the genetics and structure, which we're going to spend most of our time talking about. this is just for reference. We're going to come back to the next two slides in just a minute. But notice that it's published in terms of what the different combinations are. If you notice, for Immucor, for example, up at the top left of the slide, you see that there's polyclonal variants of anti-D. There's monoclonal variants. And it tells you what the particular monoclonal blends are, etc. as you go across. And that's what the previous slide was primarily for manual or tube testing. This is the slide that shows you the combinations for automated testing. And again, I don't want you to go into great detail on this because we're going to come back to this later. Obviously, there are also different forms of testing that we use. Commonly, or with increasing frequency, gel testing is being used to test for the presence of D antigen. More on that in a minute. A few places are using solid phase testing. You see solid phase testing there. We're not going to go into great detail on the differences. That's a topic for another day as well. I do want you to notice this. This is from an article published earlier this year in 2012 that looked at the percentage of laboratories using each method for Rh determination. And notice on the left that the main ones are tube and gel, and the liquid micro-well test as well, and then solid phase at the bottom. Back in 2005, 90% of labs were using tube, 8.7% were using gel. If you look in 2010, you see that number has actually changed significantly, and more places are using gel, and this just graphically shows, this is modified from that previous data, showing the increasing amount of gel testing that's being done. Theoretically, gel testing is more sensitive. That could lead to a scenario where someone who was called D-negative in the past with tube testing is now called D-positive. The differences in sensitivity probably are not that great, however, but their different complexities and different platforms could lead to that type of a scenario. All right, moving on to the really what this lecture is about, the differences between weak D and partial D. Before we do that, we have to talk a little bit about epitopes. Epitopes are simply antibody binding sites. I mentioned that before. RhD has over 30 of these epitopes, as I mentioned before, but let's just imagine 3 of them. We're just going to make these up, and we're going to look at 3 different epitopes on the surface. In order to have a complete and intact D antigen, you have to have all of your epitopes. If you have all of your epitopes, and we're just going to illustrate that by having these 3, you are really truly D positive. Okay, well now what does that mean? What we're trying to avoid primarily when we're talking about D variants, when we talk about the D antigen and interactions in general, is we're trying to avoid the scenario where a D positive red cell comes in contact with a person who is D negative. In that scenario, we very commonly make anti-D. It used to be said that happened in 80% of cases when a D-negative person got a D-positive transfusion. Turns out that's probably not true. The number is closer to the low 20% range in hospitalized patients at least. But that interaction there is what I want you to keep in mind, because that's what we're trying to avoid, the D positive going to a D negative. And again, it gets more complex, and follow me through on this. We're going to illustrate those epitopes by this little diagram. This little diagram excuse me, shows a D positive red cell having will illustrate this as a normal, quote-unquote, amount of D antigen with normal D epitopes, showing those epitopes 1 through 3. Now, I've modified this diagram from an article by a group that includes Dr. Mark Yazer, who gave me permission to utilize this illustration, so I just want that known up front. I'm deeply indebted to their work. When we talk about the D variants, as I said, weak D and partial D are what we're going to spend most of our time on, where we talk about a decrease in the amount of normal D for weak D, a lack of particular portions of the D antigen for partial D, and Del will talk about it in a little while as well. But let's focus on weak D and partial D. Historically speaking, weak D was thought to be a quantitative D deficiency. It was seen in about 1% of people who really were D positive, and it was defined simply by what I showed you before, the need to perform an IAT, or a weak D test, to prove that the person is D positive. Originally, we thought that this was positional, and that was called the C in trans effect that you see on the slide, on the bottom of the slide. And let me show you what C in trans looks like. Specifically in a scenario like this, where you have a person who has the genotype of big R0, little r prime, it was thought that the C gene in little r prime, when it was on the opposite chromosome, in other words, in trans, to the D gene on big R0 that inhibited the expression of the D antigen or the transcription of the D gene, and it led to a quantitatively decreased amount of D antigen. As it turns out, that's true, but it's responsible for much less of weak D than we used to think it was. Again, historical weak D was defined by the need to do an IAT, but currently, with the monoclonal polyclonal blends that we use now, almost all D-positive people are really D-positive at immediate spin. That includes people that would formerly be called weak D. So it's certainly possible, thinking back to our case examples at the beginning, for someone who's been D-negative forever or seemingly forever to suddenly turn up as D-positive if your reagent changes, for example. Now this is specifically looking at weak D. When I say that almost all D-positive people, that includes the majority of people that will be called partial D. We'll talk about them in a while, with a couple of exceptions that we'll go over. So here's historically the way this has looked. Here's a D-positive person with a normal amount of D antigen having normal epitopes. Weak D person would have a smaller amount of D antigen, but with normal epitopes. Again, that's a classic look at this, and this is classically how it was thought, and that led us to looking at these people with weak D to determine just how weak they were. Well, weak D has a lot of different forms, and we'll talk about it in a minute. The most common forms are types 1 through 3, where you have only about 500 to 2,000 copies of the D antigen on the surface, whereas normal is anywhere from 10,000 to 33,000 copies of D. So as you can see, the most common forms of D, at least in weak D, at least in Caucasians, give you a significantly decreased amount of D antigen on the surface. So again, classically, we've defined weak D people this way. On the left, they have a normal amount of D, a decreased quantity of D. They have a normal form of D, as in they have the normal epitopes, but they have a decreased quantity of D, and as a result, they are really D-positive, and if you expose them to D-positive red cells, they don't make anti-D at all. Now, as we've learned more, we've gotten a lot more information on weak D, and we found that the vast majority of these are caused by mutated forms of the RhD gene. And if I looked on the RhesusBase website, which you can just Google, the site was initiated at least by Dr. Bill Flegel. I think it's still maintained, at least in part, by him. But as of May 2012, there were 72 different genetic weak D RhD alleles. They're usually point mutations or single nucleotides, and those mutations lead to amino acid changes within the membrane. And that's really important, in the membrane or the intracellular parts of RhD. And if you look, again, this is from Connie Westhoff's article, you see every place where you see a black dot is a mutation that is associated with weak D. Again, the vast majority of them are either in the membrane or inside the red cell. It's thought that leads to decreased binding of the D antigen to the red cell surface, so as a result, a decreased amount of functional D present at the surface for detection. Again, I mentioned types 1 through 3 are the most common in Caucasians, make up 90% of weak D in Caucasians. More on that shortly. Again, another example from Bill Flegel's article in 2006, where every place where you see a red dot here in this particular illustration are forms that are weak D amino acid changes, again, primarily in the membrane and inside the red cell surface. So what does this mean? Well, if you're weak D as a donor, and your red cells go to someone who is D-negative, you have, in theory, normal D antigen, though you have a decreased amount. So the possibility exists that you could form an anti-D, that recipient could form an anti-D. As a result, we're trying to avoid that interaction as much as we can. If your weak D is a donor, however, and your blood goes to a D-positive recipient, that in theory shouldn't cause any problem at all. And if the reverse situation happens, in other words, if you're weak D as a recipient, you could always get D-negative blood, clearly. If you get D-positive blood, at least the way we historically defined weak D, that shouldn't, in most cases, be an issue. There are exceptions to that we're going to talk about shortly that has led us to look at things in a slightly different way, but again, hold on to that thought for a minute. So historically defined weak D persons as donors have to be called D-positive. So as a result, if someone is a blood donor and they initially test D-negative, they have to have a weak D test to prove that they really are D-negative. Okay, as a recipient, though, on the other hand, most people can receive D-positive blood. with a few exceptions that we'll talk about later, but certainly everyone who's weak D as a recipient can receive D-negative blood. That wouldn't be an issue at all, other than your D-negative blood supply. But remember, the vast majority of people who really are D-positive test as D-positive because our anti-D reagents are so good. So the traditional thought of trying to preserve your D-negative or not waste your D-negative blood supply on weak D people probably is not all that valid, because hardly anybody's going to test that way anymore. More shortly. So with those requirements, it should be obvious that you have to do a weak D test or an indirect antiglobulin test on any D-negative donor, but that is optional for most D-negative recipients. In other words, if you're D-negative as a recipient, then going on to do a weak D test to prove that you really are D-positive, it may or may not be of value. In fact, most places now do not do that test, and there's actually some very good reasons for that we'll cover when we talk about partial D. Partial D, on the other hand, historically speaking, was thought to be a qualitative D defect. In other words, they may have a normal amount of D antigen, but those D antigens lacked particular epitopes. More on that in a second. And as a result of that, if you were partial D and you saw someone who had an intact D, you could form an antibody against the parts of D that you lack. And that classically would lead to the finding of an anti-D in a D-positive person. We talked about that in a case earlier. It was originally described in 7 categories. Those categories have been completely blown away now. We don't use the categories anymore. But there is some residual in terms of the terminology. So again, here's how this looks. You have D-positive on the top, normal D antigen, normal epitopes, weak D on the left, which has decreased amount of D antigen with normal epitopes. Well, partial D traditionally was thought to have the normal amount of D antigen, but missing an epitope, and you see right there that missing epitope 2. Well, let's look and see how this is important. Well, let's imagine that you are a recipient. This is the interaction that causes the most trouble in people that are partial D. Let's say that you're a recipient and you're partial D. Oh, I have to make you partial D, so I'm going to make one of these epitopes fly away. Okay, so you're partial D and you receive blood from a D-positive donor. Well, in that setting, what can happen is you can form what looks for all the world like an anti-D. You're D-positive, but you make an anti-D, but it's really actually an antibody against that particular epitope. But it acts just like, functionally, it acts like a monoclonal anti-D, and that can cause, obviously, that leads to a situation where someone's D-positive and they make an anti-D. Okay, so again, traditionally speaking, this is how that looked. Abnormal D in terms of epitopes, missing an epitope. You have a normal quantity, and you make anti-D when exposed to D-positive red cells. In the modern world, we've discovered that there are many very well-described genetic mutations, and it's most commonly that gene conversion thing that I showed you before, with mutations that lead to amino acid changes in the exterior part of RhD, as opposed to, remember, with weak D, the changes were in the membrane and inside. With partial D, the changes are actually on the outside. And you would expect that, since we primarily think of partial D as an epitope issue. Every place you see a black dot in this particular illustration from Connie Westhoff's article, you see it's an example of something that can cause a partial D. Again, this is from Bill Flagel's article, and the blue changes are partial D amino acid changes. In terms of the nomenclature, I'm not even going to talk about it much. I've already mentioned that we used to use categories. It's really a mess. We still use Roman numerals that kind of correspond to the previous categories, such as D3A, which is the most common form of partial D in African Americans, and D6. Remember, that looks like DVI, but it's actually D6. Don't say DVI or people will laugh at you. But there's a lot of new and different abbreviations. There's certainly over 75 genes that cause partial D. So it's kind of a disaster. I showed you this before, the genetics and the gene conversion thing, and here's some of those examples. The top two being, remember, D6, the most common in Caucasians, D3A, the most common in African Americans, but there are different varieties, which you certainly don't have to memorize. In terms of testing, how do partial D red cells react when you test them with modern forms of anti-D? Well, actually, most common partial Ds are just going to test as D-positive, and you're never going to know. And there's one big exception to that, and that's the D6. D6, again, the most common form in Caucasians, will test as D-negative on immediate spin. Most of the others are going to be D-positive, and that's true for really whatever platform you use. And this goes back to what I showed you before, the modern forms of anti-D. These are anti-D that are used in tubes, and I've highlighted D6. You notice on immediate spin or on initial testing, D6 is pretty much always going to be negative. But if you follow that out, if you do an IAT, it's going to turn out to be positive. So if you're a D6 person as a blood donor, you may initially test as D negative, but then if you do the weak D test, you're going to test as D positive. So essentially, partial Ds are pretty much always going to be D positive as blood donors because we're required to do the weak D test. You notice there's some other forms of partial D that are negative on immediate spin, but most of them, the most common ones are, aside from D6, are going to be D positive on immediate spin. This is also true for partial D samples on automated platforms, as I mentioned before, such as the Echo system, the ProView system, and the Olympus system, etc. All those are going to test D6 as negative, and most of the other ones are going to be positive. Okay, so what does this matter? If you're partial D positive as a donor, if we don't pick you up as D positive and we give your blood to a D negative recipient, then that recipient is going to make an anti-D. It really doesn't matter that you lack that one epitope or more than one epitope. You're going to have enough epitopes that that person is going to be susceptible to forming an anti-D. On the other hand, as a recipient, if you're D negative, if you get blood from a D negative donor, that's no issue. And I showed you this slide before. We're trying to avoid this situation where you get blood from a D positive donor and you make an anti-D. So functionally, what this means is that as donors, people who are partial D need to be called D positive, and I mentioned before, most of them are going to be because we have to do the weak D test, and we would pick up those D6s that test negatively. Most other partial Ds are going to test as D positive initially. And as recipients, they need to be called D negative. Now that's where we run into issues. If a partial D person is best described as D negative as a recipient, if you take their testing, for example, if you take a D6 person who's going to test negative by immediate spin or negative on initial testing, and then go and do a weak D test to prove that D6 person really is D positive, then you're going to end up doing exactly what you don't want to do, which is to give them D positive blood. So that being said, we'll come back to that in just a moment. We always like to think of things in nice, neat categories. Unfortunately, there is a category that kind of comes in the middle of this. It's not an official category, quote unquote, but what we've noticed is that there are people who have both qualitative and quantitative RhD defects, and they cross over some of those nice boundaries that we've established for ourselves in previous years, and some people call those partial weak D. It's like I said, it's not really official, but what we've seen is that people that are weak D, for example, types 4.1, 11, and 15, if you give them D positive blood, guess what they can do? They can make an anti-D just like a partial D person. And if you look at certain forms of partial D, for example, the most common one in Caucasians, partial D6, it's actually weakly expressed D antigen. In other words, it has fewer of those abnormal D antigens on the surface. So there is definitely a lot of overlap, and it complicates things pretty substantially. So again, here's showing weak partial D down at the bottom, that that individual has an abnormal form of D and that they lack epitope 2, and they also have a decreased amount of the D antigen because they, just like weak Ds, they don't have as much. They don't have as much as they're supposed to. And that leads us to this middle category. We don't think it happens very often, but it absolutely can happen where the person has both an abnormal D, missing an epitope, decreased quantity of D. Most importantly, when exposed to D positive red cells, normal D positive red cells, they can make anti-D. So as a result, if you have, for example, a recipient who's D6 or weak D 4.1, for example, if they test as D negative initially, and then you go on and do an anti-human globulin test or an IAT test, and you prove that they are D positive, that's really not something you want to do as a recipient, because you're going to end up putting them in a situation where they're at risk for forming anti-D. And how would that work? Well, the AHG comes along, shows you that the person really is D positive, and that in this particular case is a fail. You don't want to do that. If those people get D positive blood, they may very well make anti-D. So bringing this around, what does this mean for other patients? Well, for recipients, we've already said, if you're D negative, you probably should be left as D negative because of that potential for a weak D person or a partial D person to form anti-D. What about obstetric patients? Well, obstetric patients, you should basically treat them the same way, in my opinion, as recipients. In other words, if someone is If someone is D negative on initial testing, you should leave them as D negative and treat them as D negative, even if that means that they've been treated as D positive elsewhere. The reason for that is that people who are partial D should be left as partial D because partial D moms exposed to D positive red cells have made anti-D. So partial D moms should get Rh immune globulin when it's indicated. So RhAG is indicated, as I said. Weak D moms, on the other hand, the very few weak D moms will make anti-D. However, there is a growing body of thought that it's not the worst thing in the world to give anti-D to someone who tests initially as D negative as a mom. Again, we're not talking about very many people because most people that used to be weak D are going to test as D positive now. But if someone truly does test as D negative, it's probably, just like recipients, best to leave them as D negative and give them RhIg when indicated. Okay, how does the rubber meet the road here? This primarily applies in transfusion services because obviously in blood centers, if a person's D negative, you are required to test them with a weak D test. But in transfusion services, it's best to avoid IAT or weak D testing for RhD typing with negative direct agglutination. Many places are also starting to consider a lower threshold of positivity to define someone as D negative. In other words, if you test as 1+ or lower in tube testing, or even 2+ or lower in gel, some places will consider you as D negative and treat you as D negative, giving you D negative blood if you're a recipient, or potentially giving you RhIg if you're a mom. Understand, though, that doing that doesn't zero out your risk. If you do an IAT, you can, as I showed you before, you can immunize those with partial D traits. But on the other hand, if you don't do an IAT, then yeah, you run the risk of giving people D negative blood unnecessarily. So the risk is not zero either direction. You can still immunize people, and it is still a concern. But for the most part, overcalling people D negative as recipients and as moms is the most conservative and safest route. So this brings us again to a table that shows you exactly what I'm talking about. If you're a blood donor, and we are required to do a weak D test if you're D negative, that's obvious. And so as a result, the consequence is that partial and weak D donors to end up D positive, and that's fine. You want people who are partial and weak D as donors to be D positive, so you don't give their blood to someone who's D negative. On the other hand, if you're a recipient, it is best not to do a weak D test if the person is D negative. As a result, some partial and weak Ds are going to end up D negative, and you're going to avoid exposing them to D positive red cells in a few cases. Remember, most weak Ds are not going to do this, but if they do, it's probably best to leave them as D negative. Moms, treat them just like recipients with the same results. And babies, on the other hand, should be treated just like donors. And the reason for that is that when you are testing a baby for D positivity, you want to see if they're D positive at all. Because if they are D positive, they can immunize a D negative mom. So you want to, just like a donor, you want to make as sure as you can that they really are D negative. Whew, that was a lot, huh? I hope you followed me on that. A quick word on a couple of different D variants, such as DEL. Some people call it DEL, other people still call it D sub EL. The EL stands for elution. Basically, it's an extreme form of weak D expression caused by different mutations and deletions. Basically, a scenario where the person really is D positive, but you can't tell that they're D positive with our routine testing, only by eluting it from the surface. Here's how it looks. Again, a super weak form of the D antigen with probably normal epitopes. And when you throw in anti-D, that anti-D actually after incubation will bind to that red cell, but the antigen density is so low that it won't actually give you a positive test either on direct agglutination or on the IAT. So with routine testing, there's no way to tell that this person really is D negative. The only way to tell is after incubating to actually pull that anti-D off the surface of that red cell. I should say the only way to tell serologically is to pull that anti-D off the surface of the cell and prove that the cell really was coated, at least partially, with anti-D. Why do we even care about DEL? Well, we care about DEL primarily because the Asian thing. Most of the few Asians that are D negative actually are DEL, and more importantly, if someone is DEL and is called D negative as a blood donor, there are published examples of them immunizing D-negative patients. So serologically, we can't tell. The only sure way to do this, and there are some places that have done this, and it's been published in the literature. Bill Flegel, for example, has published information on this. It is to do molecular testing on D-negative people to prove that they are not DEL and they actually are D-negative. Obviously, that's not ready for widespread implementation at this point, but it may be at some point down the line. One quick word on another weird form of D that I just wanted to mention before I go, and that's the D deletion, or the D hyphen or double hyphen, also known as elevated D. It's kind of the opposite of partial D, where you get a portion of the RhD gene inserted into RhCe, gene conversion type process. As a result, you actually get hardly any big C, little e expression, but you get more D expression than normal. It's not commonly seen, and I really don't have a lot more to say about it other than just to make you aware of it. Okay, well, that is actually all for today. We've done this in a little faster time than normal. I hope that this was helpful to you. If you have any questions, please don't hesitate to shoot me an email. Again, I get a lot of questions about weak D and partial D, and I hope that this shed a little light on it for you. Again, please remember that you're welcome to use this podcast in any way you want other than rebroadcasting it to others without my permission, and please, by God, don't charge anybody for it. Hey, thanks for hanging out with me for a little while today. Thanks for listening. I've appreciated your time and enjoyed very much being with you. Have a great day.